On this week's 51%, we speak with Dr. Elizabeth Lucal of Nuvance Health about how women can reduce their risk of cervical cancer and why we still know so little about ovarian cancer.
We need to recognize that women are just not many men that have two parts of their body, their breasts and their vagina, that need different treatment. We are different genetic individuals altogether, and women's health is the way that gets highlighted.
I'm Jessie King. It's all up next on 51%.
I was standing around like one of those girls I had seen in a movie. The whole world was a movie back then. I had my sunglasses on, I wanted to be seen without seeing shy Lolita. I wasn't really in it, I didn't really get it.
You're listening to 51%, a WAMC production dedicated to women's issues and experiences. Thanks for tuning in. I'm Jessie King. There are multiple cancers for which a big risk factor is simply being a woman. Every October, of course, we recognize Breast Cancer Awareness Month, which I should note men can be diagnosed with breast cancer too. We've done a lot of interviews and stories around breast cancer year-round. So today I'd like to set aside some time to learn about two other types of cancer that women should be keeping in mind. Cervical cancer starts in the cervix, which is the opening that connects the vagina to the upper part of the uterus. According to the CDC, anyone with a cervix is at risk for cervical cancer. It typically happens after age 30, and some doctors technically classify it as a sexually transmitted disease, as the main cause is usually long-term infection with certain types of human papillomavirus, or HPV. However, as our main guest today will tell us, medical advances have helped make cervical cancer more preventable, more detectable, and when found early, more treatable. Ovarian cancer, meanwhile, is a little more complicated. Dr. Elizabeth Lucal is here to help us learn more about both. Dr. Lucal is a board-certified OB-GYN with Nuvance Health in New York's Hudson Valley in western Connecticut. She also serves as the system's vice chair of Women's Health Services. As part of that, Dr. Lucal says it's crucial to discuss and learn about our bodies. It not only helps us feel personally empowered and capable of seeking help when things go wrong, but it also emphasizes the importance of women's health overall. Because things like cervical cancer and ovarian cancer, she says, are often seen as invisible diseases.
Medicine, we talk about everything, obviously, but one of the reasons, we really don't talk about the cervix in, everyday conversation is it's not something that you see. So we talk about, I hurt my knee, or look at this, my knee is so swollen, or look at my wrist, I was playing tennis and I have this huge, bruise. We don't see this aspect of our body. And so sometimes it is kind of hard to keep tabs on it, to recognize that we need the regular screening, and that things that can affect the cervix may not be visible to our naked eye.
I guess let's start with the basics of cervical cancer. I'll rattle off what I know so far, which is basically that, it's recommended you get regular screening for HPV and cervical cancer with pap smears by your gynecologist. There's an HPV vaccine out there that a lot of people get when they're a teenager. I guess just to start off, is HPV the primary cause of cervical cancer that we should be looking out for here? Are there some other factors that can play a role as well?
So that was something that was actually a recent development. And when I say recent in medicine, I mean about within the last decade, we recognized that the main cause of cervical cancer, so for over 98 to 99% of all cervical cancers, are caused by the human papillomavirus. So that was the vaccine that you got as a teenager to hopefully prevent any infection from future human papillomavirus exposure. So the HPV, or human papillomavirus, is sexually transmitted. So the idea of the vaccine was to get you the vaccine before you became sexually active and were exposed to this virus. So there are a smaller percentages, about 1 to 2% of other cervical cancers out there that are very different in origin. They are not picked up by the pap smear. And they are things that are found during a regular GYN exam, but they are far less common than the cancer caused by HPV.
What can heighten your risk for some of those other types of cervical cancer then? Is it a matter of, the quote unquote lifestyle factors or genetics?
So yes, on the impact of cervical cancer for HPV, there are some lifestyle factors that can be addressed. The other cancers are less likely to be affected by lifestyle, but lifestyle is a very, when I say vague, it's very, again, a dynamic topic. We don't know exactly everything that could potentially impact cancers or make things worse or better. We do know a healthier person usually means for less likelihood of, badness happening, but not always. So yes, we'll always say watch those lifestyles, but for those cervical cancers that are about 1 to 2%, the rare ones, those tend to be more genetic. They also tend to be more due to exposure. If you had pelvic radiation because you had either ovarian cancer or colon cancer, something that you were being treated for, any type of radiation treatment can actually increase your risk of a cervical cancer.
As you mentioned, the HPV vaccine is typically recommended for young people once you're a teenager. Can you still get it, though, if you're older?
The vaccine now is approved to women up to the age of, I believe, 40. It used to stop at the age of 26, and the age stop wasn't due to the fact that cervical cancers were less likely in certain populations. It was more to the fact of, because HPV is sexually transmitted, the idea was the population that had a higher rate or more regular rate of sexual encounters would be the population that should be protected. But the problem with that thought process is we live in a country where our divorce rate is over 50%. So even older women have a chance of having a new partner that could potentially expose them to the HPV virus.
And when it comes to pap smears, how often should we be doing that? Is that something that you either wind down or ramp up with age, like with mammograms?
Actually, the screening algorithm is pretty consistent in the sense that the time frame in between appointments doesn't really change all that much. So there are different recommendations depending on which organization the physician either belongs to or what the physician typically practices. So the American College of OB-GYN, the American College of of Surgeons, and the United States Preventative Service Task Force all have slightly different screening regimens, but not too different. So again, any screening regimen has been proven to decrease the risk of a patient developing advanced cervical cancer. So the general idea is that most pap smears should not start until the patient is about 21. And then from that point, a patient can have a pap smear every 3 years. And that every 3 years stays until they're about 30. And then just the type of pap smear actually can change from 30 to 65. The recommendation is that you can stop pap smears when you're 65 if you've had a pretty good history of normal pap smears and you have no new lifestyle changes that would put you at risk, saying that, further screening is necessary.
You mentioned at the beginning here that this is a cancer that maybe doesn't get talked about as much because it's all internal. We don't see it. So I guess what kinds of early signs and symptoms should women be looking out for?
So sometimes women may have things like vaginal bleeding that is in between periods. So bleeding when they're not supposed to have any bleeding. At times you can have increase in vaginal discharge, but those tend to be very unlikely unless the cancer is relatively progressed. The nice thing about the regular screening or the regular pap smear that we do in this country is that we really have reduced the amount of cervical cancer that we find, and we tend to find what's called precursors, the cells that if they were left alone and if you never came back for another pap smear or a physical exam, could progress to cancer. And so what we find is that if we treat those, we still are doing a good job of preventing cervical cancer.
So how do you treat precursors?
So it really depends on what the abnormality is. So I usually tell patients that the abnormalities come in a range and I number them 0 to 4. So if the abnormality is between 0 and 1, it usually means that you're just repeating the pap smear in a year as opposed to skipping years, which is part of the screening algorithm that you can have a pap smear anywhere from 3 to 5 years. If it's abnormal, you may repeat it in 1. If it's more along the lines of an abnormal level of 2 to 3, you can come into the office for a procedure, and that procedure usually is a closer examination of the cervix, and then biopsies can be taken. And then from those biopsies, further changes in the screening recommendation or further procedures can be done. If a cervical cancer is truly diagnosed, then that is actually the patient is referred to what's called a GYN oncologist. And that GYN oncologist will talk to them about surgery, which is usually to remove the cervix and the uterus. And then they talk about other things that can go along with that surgery. And then will that patient need any treatment in the sense of radiation or chemotherapy? Again, fortunately, being in a resource wealthy country, while we do have cervical cancer, we are finding more precursors to cervical cancer, and those are treated by your general GYN.
It sounds like over time we're getting better at treating cervical cancer then, that the prognosis is getting better.
In this country, we are. Unfortunately, though, what we are also seeing, and it's not yet clearly understood why, although we're seeing some earlier lower grade cancers decrease, there is also a slight, and I emphasize slight, but there is definitely a noticeable increase in advanced cervical cancers among patients. And we're not clearly certain as to why we are seeing that, since we do recognize that with the advent of the vaccine and with regular screening, we are seeing a lower rate of some of the earlier cancers than we did before.
I'd like to talk a little bit about ovarian cancer too. I tried to do some research before our conversation, and a lot of what I was finding when it comes to causes and signs is basically we don't know. It sounds like, there's still a lot in the dark when it comes to ovarian cancer.
Absolutely right. Ovarian cancer is one of the, I would say one of the many nemesis of the GYN world, as there are no good screening tests for it yet. There are so many models or, testing algorithms or blood tests that are being marketed, but right now there is no formal approved screening test for ovarian cancer, the way we have a screening test for cervical cancer, which is the pap smear. So ovarian cancer, we don't really have that. It's based on symptoms. It's based on what can we look for a patient that may be high risk, and then basically taking that family history and determining some of the genetics that we do know now impact ovarian cancer.
So what should people be looking out for then? I know, are there any signs or symptoms that could be signaling that something is wrong?
So the ovarian cancer that most women are concerned about, and the one that we hear about in the news, the one that is the silent killer, so we call it, is definitely a cancer for the most part of older women, although there are those families that have the genetic predisposition to having a very aggressive cancer. So you can see that sometimes in patients who are younger, so in their 40s. So what we're telling patients, especially when they are menopausal or postmenopausal, is that if you've had weight loss of unknown causes, if you have fevers of unknown causes, if you have abdominal bloating, pelvic pain, those are reasons to, talk to your GYN or talk to your primary care and see if there are things that should be evaluated, whether by imaging or whether by exam, and see if there's anything that can be found. But they're very vague. The symptoms can be associated to a whole bunch of other illnesses or other causes. And so that's what makes it so difficult to determine if a patient truly has something that's concerning for the ovary until you actually potentially see a mass on the ovary that can be sampled.
You mentioned that genetics and family history can have a big influence. Do you mean the BRCA1 and BRCA2 genes that also play a role in breast cancer?
Those are the two most, I won't say most common, those are probably the two that are most well known. There are definitely other combinations of letters out there that are abbreviations for different types of cancer mutations. So yes, those are the ones that we're talking about. They take the risk of ovarian cancer and make it much greater. So the risk of ovarian cancer in the general population is relatively low. But you have one of the BRCA genes or another one of the ovarian cancer genes, you are pushing that risk to a much higher level. We're talking anywhere sometimes, depending on the gene itself, to the 30%, 40%, and sometimes even 50% range. So that's actually not saying if you're going to get an ovarian cancer. That's basically saying when are you going to get it. So those types of findings in families change how we counsel those patients, change how we talk about a plan. That's where we talk about sometimes what's called prophylactic surgery. So after a certain age, removing the ovaries so that risk of ovarian cancer is gone.
And what's the prognosis with ovarian cancer then? Is it relatively treatable?
It definitely depends on at what stage that you're diagnosed. So if you are finding the cancer early, and I have had patients where it was found almost happenstance, but very early, surgery, removing the ovary and the tube is curative. Other times it's treatment where it is removal of the ovaries and the tubes and radiation, and then basically the prognosis, I won't say is grim, but can be very difficult. So the stage matters as to when or how well a patient will do.
I guess, why do you feel that we know so little about it? Is it something that could be helped with increased funding for research? Because I've done previous episodes on endometriosis, and a lot of the conversation around that was endometriosis is something that actually is pretty common for women to face, but there's still so much we don't really know about it because it doesn't get that funding.
Funding is always going to be something that's helpful. I think the other thing that is always helpful is that conversation. So, ovarian cancer, cervical cancer, breast cancer, these are things that women know about, but we still don't always talk about. No one likes to come in for their well woman exam. It's not the most comfortable exam, but again, women need to empower themselves and realize that these are conversations that are okay to have with your physician, with your nurse practitioner, with your midwife. These are the things that we're supposed to be talking about and hunting down the information, for you. These are the questions that come up so that we can discuss, well, what is your family history? What makes you concerned that you have ovarian cancer? Or what makes you concerned that you're at risk? Are there things that you can do to improve your lifestyle? Are there things that you can do to decrease your risk? And that just doesn't go for ovarian cancer. That goes for almost any aspect of your life. So as funding will always be an aspect of any type of research, just also being aware is the first step, so that the more patients are demanding that these questions be answered, the more medicine is pushed to say we've got to get these answers.
Well, on that note, as someone who has helped women with both of these diseases, is there anything you think people frequently misunderstand about them?
Definitely. So cervical cancer patients are mortified when I tell them that cervical cancer, for all intents and purposes, is a sexually transmitted infection. Mm-hmm. So it does matter when we talk to patients about safe sex practices. It does matter when we talk about knowing who your partners are and feeling comfortable about asking, have you ever had a sexually transmitted infection? It does matter. And so those are the questions that, women can ask. When it comes to ovarian cancer, we don't have the same screening, so we don't have sometimes the same questions to say, go out and ask this. But understanding your family history is also a first step in improving your own health, because we are connected to the generations behind us just through our genetics.
Well, Dr. Lucal, thanks so much for taking the time to speak with me. Is there, anything else you'd like us to know before we go?
No, I think that this is great. The more we talk about it, the more we put women's health issues and women's concerns, front and center. I think the more women become, not second-class citizens in our own country. We need to recognize that women are just not many men that have two parts of their body, their breasts and their vagina, that need different treatment. We are different genetic individuals altogether, and women's health is the way that gets highlighted.
Dr. Elizabeth Lucal is a practicing OB-GYN and the Vice Chair of Women's Health Services for Nuvance Health in the Hudson Valley in Western Connecticut. To learn more about her work and Nuvance Health in general, you can check out nuvancehealth.org. Dr. Lucal, thanks again.
You are so welcome.
Here in New York, many teenagers are struggling more with their mental health since the pandemic. Our Capitol correspondent Karen DeWitt takes a look at what the state is doing to help alleviate the crisis.
Governor Kathy Hochul and the legislature invested $1 billion into mental health services in the current state budget. Part of that money is earmarked for services specifically for teenagers. Health leaders, including the U.S. Surgeon General, say a recent spike in mental health challenges among young people has had a devastating effect.
Good morning to all of you. Thank you.
The governor spoke at a summit on youth mental health back in June. It followed a 3-month-long listening tour hosted by Hochul and led by a team of mental health experts, where over 200 youth spoke and shared their struggles. The governor blames COVID pandemic-related lockdowns and the influence of social media for the increase.
Teenagers are facing a crisis like never seen before in the history of this country. There was a time when it was always binge drinking, drunk driving, smoking were the greatest evils. Today it's so much deeper. It's anxiety, it's depression, and it's suicide. If you look at the statistics, they're absolutely staggering. And it's just a reminder that we're failing our children.
She says that according to the CDC, 42% of high school students feel persistently sad or hopeless, and 22% say they have considered suicide. The numbers are even higher among LGBTQ youth. This year's state budget includes $10 million in grants to suicide prevention programs targeting high-risk youths and a $20 million expansion of mental health services in schools by increasing Medicaid reimbursement rates for school-based mental health clinics. New York's Commissioner of Mental Health, Dr. Anne Marie Sullivan, says the goal is to have a mental health clinic in every school in the state. Speaking to public television's New York Now, she says 1,000 clinics exist now. Another 200 to 300 are in the works.
They can talk to a mental health professional. That youth can get some services right there in the school in a non-stigmatizing way. So that's a major initiative to have those services available.
She says there's also a 24-hour counseling and crisis line reached by calling or texting 988. Those who need more care are referred to a hospital, a clinic, or a therapist. She acknowledges, though, that there is a severe shortage of qualified therapists to meet the need. Sullivan says her agency is working with schools to encourage career paths in mental health treatment.
We've already been talking to some high schools to let us come in and speak with them, and colleges, community colleges. So I think we really need to talk with social workers when they graduate. What do you want to do? You know, there's different things you can do with the social worker, or nurses, or physicians, whether you want to become a psychiatrist. So it's engaging people.
She says the state also offers student loan repayments to doctors who want to specialize in psychiatry and to nurse practitioners who want to work in the mental health field. Sullivan says this year's budget also includes money for partial loan repayments for psychologists, social workers, and mental health counselors, as long as they agree to work in a public health clinic for a period of time. In Albany, I'm Karen DeWitt.
We're going to close things out today with a conversation about how we can get the most out of our doctor's appointments. Alison Joseph is a national board-certified nurse practitioner and wellness speaker, while John Brown is a state-licensed LPN with a background in primary care, ophthalmology, and neurology. Together, they've created their own telehealth business in New York's capital region called JBA Concierge Medicine, in the hopes of providing a more personal service to a broader clientele. The pair recently spoke with our associate producer, Jody Cowan, about the benefits of receiving care at home and how we can be better stewards of our own health.
I have the two of you here. This is the team.
This is it. This is the beauty of it. If you call, you're going to get one of the two of us. If you send a message, it's one of the two of us. There's no layers that you need to get through. This is it.
What is it that folks are coming to you with these days?
You know what? There's absolutely acute illnesses, but people are just nervous. They're nervous that they have all these issues, that they just want to be... They want to know that they don't have these issues. They want those issues proven. Yeah, they want reassurance. And some of those issues we find out, and then we come up with a plan. How are we going to tackle that one day at a time? There's always options.
Can we talk a little bit about being better patients? How can we address our own health in a way that we can better recognize what's going on, that we can then share that information with you?
Absolutely. That's such a good question. I think there's so many important players when you go to an office. The most important players, of course, are going to be the person that rooms you, who is sometimes a nurse and sometimes isn't, and the provider. And so sharing, because I've had amazing nurses who share that information with me that the patient gives them, and it really helps the full picture. So really, if you're going to go to a big, huge practice that has a lot of different players, remember you have to be patient. And they may know you well and they may not, but you have to know where you are. Etiquette, being polite, and really trying to be patient and taking your time, allowing that provider to take their time is important. I know it's very hard. Advocacy. People need to know what is important for them to advocate for. Having a list of what your medications are, what medical diagnoses you have, what allergies you have, all of these things, and carrying that around with you is very helpful.
As well as family medical history.
Family medical history is so important. Mm-hmm. And having that with you is important so that the doctor or the provider can get a good picture of what exactly the issues are, and maybe that might be easier for you to explain. It's hard for people to understand how they can advocate for themselves, and that's such a bigger conversation. But also the most important piece is continued dialogue. I often have had patients who say, I went to that provider, they didn't listen to me, my questions weren't answered, and then I came home and I had more questions. Okay, It's okay to go back to that provider. I always say that it's okay to go back, continue dialogue. It's a relationship. It's like a marriage. You continue to talk. If you then feel after one or two visits where you go back that you're not heard, then maybe you need a new provider.
There's lots of studies available for every type of modality that you're looking for.
Absolutely.
You need to know what your body does, what it doesn't do, what it can't do. Learn your limits. And all of those things will help us provide for you a lot better.
We need you to be a part of the care. It's not just that you come to us or any provider, they give you medicine and you leave. Your provider is always going to prefer for you to really be a part of your care. And it's where you're going to get the best outcome and feel the best, which is exercising, meditation, stretching,
yoga,
therapy, whether it's physical therapy, mental therapy.
Health therapy.
It's going to be a team effort.
By the way, apples are really good for you. Eat an apple a day. They're really good for you.
Add some kale with that, too. You don't want too much sugar.
Right.
But you really want to diversify your life, your body. Your body is important, too. I know we're running around doing 1,000 different things, but this is important also.
And it seems like it's important to do, that daily check-in and not just waiting until something hurts or something is ailing us to kind of reach out.
So as we age, Jody, and I don't know if you're in this age group, but as we age, there's like a new ailment every day. It's like a surprise. Oh, what it's going to be today? What's it going to be tomorrow? But if you notice after a week or so, it's still there. You can't stretch past it. There's nausea, vomiting. There's pain at night. There's some red flag symptoms. Then maybe you just need to reach out. And sometimes you just reach out to the nurse and say, hey, what do you think? And a lot of times they'll say, let's just put our eyes on you.
Right.
And we'll just make that easy and, reassure you.
How did you guys come up with your culture of care?
Well, I think a lot of times people are really unhappy with the way that the pharmaceuticals make them feel. They're unhappy with the side effects. And a lot of times we can see that patients are on multiple medications, and some of them are just to treat the side effects of the pharmaceuticals. I'm not against pharmaceuticals. I think they're amazing, and they really preserve people's lives and give them a great quality of life. I just think that there's another piece to it. And there's different cultures of medicine over time. And there was a culture that was very centered on pharmaceuticals, and you didn't really need to do anything proactively. And I think that's over. I think we're moving to a new space. I think we have new generations, younger people that want to do things different. The older population is now really into CBD and cannabis gummies. They're really into that. I have my 80-year-old father who's like, where do I get this? I can't sleep at night. And this is a generation that was completely against it, that was totally into the war on drugs. Things have evolved and changed, and you can just go to your local dispensary now.
That was nurse practitioner Alison Joseph and LPN John Brown, founders of JBA Concierge Medicine, offering telehealth appointments in New York's capital region. They spoke with our associate producer, Jody Cowan. You've been listening to 51%. 51% is a national production of WAMC Northeast Public Radio in Albany, New York. It's produced and hosted by me, Jesse King. Our associate producer is Jody Cowan, and our theme is Lolita by the Albany-based artist Girl Blue. Just a reminder that you can listen to 51% anytime at WAMCpodcast.org or wherever you get your podcasts. And you can stay in the loop on all of WAMC's shows by signing up for our weekly newsletter Airwaves at WAMC.org. We hope you'll join us next week. Until then, I'm Jesse King for 51%.
I was every single girl, I was nobody else, I was so sure of myself. I was 15 and a half, he was a hollow laugh. And I lost my cool somewhere along the way. At night, down the hallway, I had to learn how to look away. I lost my cool, no electricity, hot rain on the concrete, sweet melting little girl dreams. They said, oh, I want a big life, not a house that could have been like. Where are you taking me? Where are you taking me? Said